distal radius fracture in elderly population. So distal radius fractures are most common upper extremity fractures. Um, how we define elderly is important. There is no universally accepted criteria. Literature states and UN states that age above 60 is a cutoff for geriatric. WHO and many other organizations do use an age of 65. It is important to think about osteoporosis and functional level more than the age factor alone. A risk factor for distal radius fracture is white race, female sex, osteoporosis, low on vitamin D, seasonal variation. Elderly are higher risk of slip and fall on ice, higher cognitive motor function in elderly, more likely to brace a fall. Regarding the osteoporosis, has a relationship with the distal radius fracture. Uh, Fracture groups have low BMD and DEXA and more patient T-scores of less than 2.5 in forearm. Some postmenopausal women exhibit high bone loss preferentially at distal radius. This has been shown by Satoshi et al. In 2020 in JBGS. Regarding the treatment, whether we have to splint the patient, long or short arm splints have comparable results. Short arm splints have better tolerate for the patient. A question is, does osteoporosis really delay healing? Addressed by the Gother et al. 2020 paper. It was a retrospective study of 311 patients, and in osteoporosis there is a 28% chance of distal radius fracture, but no effect on distal radius fracture healing itself. Age is a risk factor for displacement. Age is significantly associated with later displacement. Age more than 80 has 4 times likelihood of late instability than a patient of 30 years old. This has been quoted by McKinney in JBJS. Compare distal radius fractures managed operatively with non-operative treatment. 90 patients were taken by Igol et al., treated with or without surgery for displaced distal radius fracture, extra-articular fractures. They found no difference in wrist extension, dash score, and complications. Grip strength and radiographic outcomes were better with the operative group. Regarding intra-articular fractures, it has been quoted to have 25% risk of redisplacement if they are treated conservatively. A comparison again with operative versus non-operative distal radius fractures. A meta-analysis has shown no improvement in median term, that is less than 1 year, in dash score with the 60 plus age group. The grip strength does improve with operative group of all ages. Significant difference in complication rate in favor of non-operative treatment compared with other studies that include 18 patients 18 years or older. Regarding the non-operative versus ORIF, a summary is that what are consistent with the normal study is that grip strength, radiographic outcomes, and early function improve with surgery. Complication rate is worse with surgery, while the healing ability is almost equal. Regarding usage of non-locking plates and screws in osteoporotic patients, there was a study conducted by Benjamin et al. In 2016, which showed no difference between the groups in development of loss of fixation. So there was a conclusion that there is no benefit of locking screws in osteoporosis fractures. Regarding external fixations versus volar plate fixation, there is almost the results are comparable and there are similar results. There is no difference between the dash score and grip strength. This study was basically between uh, distal radius fractures which are displaced dorsally. Some of them were volar plating and some were on external fixators. It has been shown by Neil et al. In 2012, patients who were treated pharmacological intervention had 48% less likeliness of again sustaining a distal radius fracture. A trial was conducted in 2019, and this trial was trying to assess if the hand therapy is needed in distal radius fracture, and the RIST trial has shown that the hand therapy is not necessary for older patients with distal radius fractures.